This is an unfolding case study over liver disease, specifically covering alcoholic cirrhosis by Jocelyn Soto. Day 1, we have a patient by the name of Michael Scott, who is a 57-year-old Caucasian male who was brought into the hospital with reports of mental status changes of feeling confused, weak, and agitated. Michael's sister brought him into the hospital after she says she went to visit him, and he was complaining that his stomach was killing him and wasn't acting himself. She says he seemed very confused, agitated, and was stumbling. His sister states that Mr. Scott is a chronic alcoholic, but has been sober the last couple of years. She also said that he has been a chronic alcoholic for 12 years, is divorced because of his drinking problem, and has lost his job last year due to COVID-19. Let's take a look at Michael Scott's medical history. His history shows that he has cirrhosis directly related to alcohol abuse, hypertension, portal hypertension, splenomegaly, and thrombocytopenia. Here's a question to get you thinking. Why is someone with alcoholic cirrhosis at risk for portal hypertension? Because of the restricted blood flow through the portal vein in the liver. Portal hypertension causes blood to be rerouted to adjoining lower pressure vessels. Cirrhosis is the most common cause of portal hypertension. The increased pressure in the portal vein causes large veins, or also known as varices, to develop across the esophagus and stomach to get around the blockage in the liver. Portal hypertension also increases the production of lymphatic fluid from the liver, and this fluid weeps from the surfaces of the liver into the peritoneal space, also known as ascites. Moving on to our initial assessment, Mr. Scott appears to be confused, agitated, and has slurred speech. He is alert and oriented ×1 only to self. His abdomen is distended and rounded with positive fluid wave test. Skin and eyes are yellow, indicating possible jaundice. He has spider angiomas on his face and arms, has non-pitting edema bilaterally, and lower legs, lungs, and breath sounds are clear bilaterally. Here you see a spider angioma and jaundice. His current vital signs are as follows. His heart rate is 109, respiratory rate of 21, temperature is 99.8 Fahrenheit, taken orally. O2 sat is 91%, and blood pressure is 129/88. What labs do you think the provider will order for Mr. Scott? If you were thinking CBC, CMP, and LFT, that will be correct. A provider would order a CBC because people with alcoholic cirrhosis are known to have impaired coagulation and also decreased platelets because of splenomegaly. And since Mr. Scott has a history of splenomegaly and thrombocytopenia, we would want to look at his complete blood count. We'd also want to look at a CMP to monitor his electrolytes. Patients with alcoholic cirrhosis can have hyponatremia from hemodilution, hypokalemia, and hypocalcemia due to malnutrition and altered renal function. And LFT will also be monitored to check their liver function. Albumin, which would show low possibly, and bilirubin high. Which assessment findings should be reported to the provider immediately? The nurse should report his altered mental status, because mental status changes, confusion, and slurred speech can be a sign of hepatic encephalopathy, which could lead to seizures, coma, or death. Here you'll see his labs. His complete blood count is not too bad. Platelets are relatively low, as we would suspect in alcoholic cirrhosis. You see here his ALT and AST are elevated. What's most concerning is his albumin level, which shows a 1.3, which is low. His ammonia, which is very high at 77. His bilirubin is also high at 4.6. He is showing a little hyponatremic at 132. Potassium sitting at 3.4, which may be normal for him, and calcium is a little low. The provider has evaluated Mr. Scott and diagnosed him with hepatic encephalopathy based on his ammonia levels and positive hysterexis. The provider has also recognized he is having complications from ascites, but wants to resolve the encephalopathy before treating that. The provider orders the following: oxygen 2 liters per minute via nasal cannula, lactulose 30 milliliters by mouth every 2 hours, 100 milliliters an hour of normal saline, and to restart his home medication of Nadolol 40 milligrams by mouth once daily for his portal hypertension. He also wants him to be on telemetry monitoring and also ordered an abdominal x-ray and abdominal ultrasound. So what is asterexis? Asterexis is a coarse tremor characterized by rapid, non-rhythmic extension and flexion of the hand when the arms are extended and the hands are bent upwards. It is associated with metabolic encephalopathies and presents as hand flapping motion. Bilateral asterexis is most commonly associated with hepatic encephalopathy. Moving on to day 2. It is the next day, and the night shift nurse reported that Mr. Scott had 4 bowel movements after receiving 6 doses of lactulose. She says he seems more alert and less agitated. After the shift change report, the day shift nurse goes in to assess Mr. Scott. Her physical assessment is as follows. Mr. Scott is sitting up in bed watching television, alert and oriented ×3 to person, place, and time, S1 and S2 heart sounds with sinus tachycardia. Says he feels a little better, but abdomen is still causing him discomfort. Pain 8 out of 10. Abdomen appears distended, rounded with positive fluid waves. Skin is jaundiced with spider angiomas. Lung sounds are diminished bilaterally. And here are his vital sounds. Heart rate shows tachycardia at 109. Respiratory rate is at 22. Temperature 98.9 Fahrenheit orally. O2 is at 99% on the 2 liters a minute nasal cannula. And blood pressure is 136/82. The provider has ordered updated labs. Mr. Scott's ammonia level has been lowered. Now the provider would like to manage his ascites. Ammonia level went from 77 to 62. Normal range is 15 to 60. Since his mental status has improved, we will continue to monitor and give lactulose. Here are his following labs. You can see here that his ammonia is now 62, but his albumin has dropped to 1. And also his sodium is getting lower at 128, possibly due to the fluid retention. What procedure do you think the provider will perform to alleviate Mr. Scott's ascites? If you were thinking paracentesis, you're correct. Performing a paracentesis will help determine the etiology of a patient's ascites. Draining the peritoneal fluid may help identify infection, causes of liver disease, or portal hypertension. Also relieve symptoms by removing a large volume of fluid. His paracentesis results are in: after conducting an abdominal ultrasound and x-ray, the provider performed the paracentesis when it was able to pull 2,500 milliliters of fluid from Mr. Scott's abdomen. What should a nurse monitor after a paracentesis procedure? You would want to monitor vital signs because with the fluid shift and everything, he can suffer from dysrhythmias, things like that. So we want to monitor those. Maintain bed rest because he had just had a procedure done, invasive procedure, so we want to make sure he doesn't injure himself and he's a bleed risk. We want to measure the fluids because we did pull a lot of fluids from him, so we want to make sure that's not reaccumulating. We also want to document the amount and color for signs of infection. Send that specimen to the lab to see if there is an infection that has caused the ascites. Assess the puncture site for drainage, and weigh the patient. What medication do you think the provider will order for Mr. Scott? Albumin, pain medication, and continue lactulose. Albumin is a plasma expander and helps to reduce the risk of a drop in blood pressure. So for every 2.5 liters of acidic fluid drained, 100 mLs of 20% albumin should be infused through IV. Mr. Scott's pain was also an 8 out of 10, and so we would give him pain medication to help him decrease pain. We would also continue that lactulose because we want to continue to bring his ammonia levels down, because remember, he was at 62, so he was still slightly high. So the provider orders 20% albumin infused intravenously at 100 milliliters per hour. Hydromorphone IV 0.4 milligrams every 6 hours as needed for pain greater than 7 out of 10. We're going to continue that lactulose 30 milliliters by mouth every 6 hours. And also continue the nadolol 40 milligrams by mouth once daily for his portal hypertension. Okay, moving on to day 3. Night shift nurse reports uneventful night and reports he had 4 bowel movements. Our physical assessment, we find Mr. Scott is resting in bed, lung sounds are clear, alert, he is alert and oriented ×4, S1 and S2 heart sounds are noted, and normal sinus rhythm. His abdomen is round, non-distended, soft, and tender over puncture site. He has no bruising or leakage from the site. Bowel sounds are present in all 4 quadrants. Reports pain level of 3 out of 10 from paracentesis site. No reaccumulating fluid secondary to ascites. Still has bilateral edema in his lower extremities. Skin is still jaundiced, and he's complaining of itchy skin on arms and chest. His vital signs are as follows. Heart rate is 86. Respiratory rate is 17. Temperature is 98.6. And his oxygen is 96% on room air. Blood pressure is 140/80. So his oxygen indicates that with the fluid release, he is better able to breathe. What can be causing Mr. Scott's skin to be so itchy? Since he's had severe jaundice, we can also assume that he has bile salt deposits. With bile salt deposits, that can cause severe pruritus, also known as itching, and increases the risk for breakdown, which in turn increases both bleeding and infection risk. What nursing interventions can be implemented to promote healthy skin integrity? We should tell him to use warm water while bathing, because hot water can increase the itching. Use emollient lotions as needed to prevent dry skin. If needed, apply mittens to his hands to prevent him from scratching. And turn the patient every 2 hours to prevent skin breakdown. Mr. Scott is on the mend to recovering from encephalopathy and ascites. His ammonia level shows marked improvement. Since receiving albumin yesterday, his albumin level has risen to 3.2. His ammonia level has also lowered to 55. And here are his labs indicating that. His sodium has also risen to 133. So almost back to normal, but also he may just sit a little hyponatremic because of his alcoholic cirrhosis. What is one complication that Mr. Scott is at risk for following a paracentesis? Spontaneous bacterial peritonitis. Ascites can contribute to the development of bacterial peritonitis even in the absence of known contamination or infection. The development of SBP causes inflammatory response in which the increased inflammation of the peritoneal membrane increases the ascites accumulation by increasing the permeability of capillaries in the mesentery. So basically, after paracentesis, if they have spontaneous bacterial peritonitis, you will just see that reaccumulation of the ascites happen. What are some signs and symptoms to assess for spontaneous bacterial peritonitis? So this should be suspected in patients with cirrhosis who develop signs or symptoms such as fever, increased abdominal pain, altered mental status, or worsening encephalopathy, abdominal tenderness, or hypotension, and an overall decline in condition. We will continue to monitor Mr. Scott, and if he continues to improve, he will be ready for discharge tomorrow. The provider has ordered the following medications. Continuous lactulose 30 milliliters by mouth 2 times a day. His also a new order for diphenhydramine, Benadryl, 50 milligrams by mouth every 4 to 6 hours as needed for itching. Spironolactone, 25 milligrams by mouth every 8 hours for that lower leg edema he's having. And Nadolol, 40 milligrams by mouth every day for portal hypertension. Day 4 is here. And here's our physical assessment on Mr. Scott. He is resting in bed, watching television. He is alert and oriented ×4. His lung sounds are clear bilaterally. He reports that the Benadryl is helping with his itching. His skin is still jaundiced with noticeable spiderangiomas. His abdomen is round, non-distended. Paracentesis site is clean and dry with little tenderness. Bilateral edema in lower extremities has gone down but is still present and non-pitting at this time, and he reports no pain. His vital signs are as follows. His heart rate is 86, respiratory rate is 18, he has a temperature of 98.4 Fahrenheit orally. His O2 is 97% on room air, and his blood pressure is 139/84. After reviewing Mr. Scott's vital signs and labs, the provider puts in discharge orders for home. His labs show the following. So you'll see here his albumin is up to 3.4, which is great. His albumin is down to 41, and his sodium is still there at 134, but that's a good sign. And his platelets are still a little low, but again, that is expected with someone who has splenomegaly. What medications do you think the provider will prescribe Mr. Scott to continue to take at home? We have lactulose, and lactulose is recommended as the first choice for treatment of episodic hepatic encephalopathy and for the prevention of recurrent episodes. Lactulose reduces the amount of ammonia-producing organisms in the bowel. So ammonia can't be absorbed, so we give lactulose to help excrete it through the bowels. He will also continue to take his medication of Nadolol to decrease his portal hypertension. He will also continue to take spironolactone to help and reduce the leg edema and help prevent the recurrence of ascites. What education should the nurse include in her discharge planning for Mr. Scott? Identifying signs and symptoms of hepatic encephalopathy, identifying signs and symptoms of ascites, and nutrition. Discharge education as follows. Signs and symptoms of hepatic encephalopathy to report to the provider. Mild confusion, forgetfulness, mood swings, personality changes, inappropriate behavior, difficulty doing basic math, change in sleep patterns, difficulty writing or doing other small hand movements, breath that smells musky or sweet, and slurred speech. Signs and symptoms of ascites to report to the provider. Large abdomen, rapid weight gain, swelling in the ankles, shortness of breath, abdominal pain, back pain, difficulty sitting, and fatigue. Also, they should do weight checks daily and call the health provider if they gain more than 10 pounds or more than 2 pounds per day or for 3 consecutive days. Nutrition education. A client with alcoholic cirrhosis and complications of hepatic encephalopathy and ascites should follow a low-sodium diet, limit salts and foods that contain salts, low protein, because high protein causes toxins to build up in the body that can't be filtered out, which causes the high levels of ammonia to go to the brain. Also high calorie but low fat, so they should have vegetables, fruits, starches, breads, pastas, cereals. They should also eat frequent small meals and avoid alcohol and hepatic toxic drugs. What liver toxic drugs should the nurse educate Mr. Scott to avoid? He should avoid acetaminophen, NSAIDs such as ibuprofen and naproxen, anti-seizure medications, ACE inhibitors, and most importantly, avoid alcohol. These are the references that were used for this presentation. Thank you for following along, and I hope you enjoyed.